Professor Schof, Professor Jakub, thank you very much for the introduction. It's a great honor and privilege being invited here to give a keynote lecture. And I would like to thank again Professor Jakub, Dr. Yoganathan, and Adrian Chester for inviting me. Now, valve conserving operations from structure to function, the big topic, and the whole symposium or conference here is about this topic. And I would like to focus the keynote lecture to the aortic root or aortic valve. And I would like to structure my talk, give you some background, and then some thoughts about structure, function, but basically you are the experts. You're the majority, as I understand, are researchers, and it would be easy for me just to refer to all the abstracts, because you're at the front of basic research, and I hardly could follow some of your talks, if at all. So I just want to scratch at the surface and give you some ideas, informations where I was involved, and I'm still involved in aortic valve, aortic root structure and functions. Now I'm at the other side of the front line. I'm a cardiac surgeon, clinician, and I would like to give you an overview about the surgical techniques, which are the surgical techniques to correct isolated pathologies of aortic root structures, and also aortic valve preserving techniques. And I think it's very important that you, and addressing the basic researchers, know also the clinical data and technique, because your goal needs to be that at one stage your findings, your research needs to be translated into the clinical setting for the patient's benefit. So I also would like to give you some clinical data, and there are some innovations. This is a fancy term, and not very new techniques, but probably the application of these techniques. So, as you know, the aortic valve and the root has been investigated already many years ago by Leonardo da Vinci, who already recognized the vortices in the aortic root. And it's composed of many structures, as you know, the sinuses, annulus, etc. And the aortic valve or root, and you already noticed that I switch in between valve and root, and I will come to that later, is incorporated in the fibrous skeleton of the heart, and very close to the mitral and also the tricuspid valve. About 45% of the circumference is attached to the LV myocardium. More is attached to the fibrous structure, and usually the non-coronary cusp or sinus is the largest one. The aortic valve and root undergoes very complex dimensional changes during cardiac cycles, so with the sinotubular junction moving inwards during diastole and the annulus moving outwards. But let's even go a step further. Let's talk about the root structures. And we performed a survey at the CTSNet, and we received asking surgeons how do they define, how they determine the different structures of the aortic root, and we received more than 530 answers. And this was the answers, an example when we asked the aortic valve consists of. And you can see here almost 30% answered the aortic valve consists of the sinuses, the tissue of the aortic wall between leaflets, cusp, the sinotubular junction, the leaflets, cusp, and so on. So the question is that valve-sparing operations are really valve-sparing, because in this way the aortic root is prepared for a valve-sparing operation. As you can see here, the sinuses are cut out. What I would like to emphasize is it doesn't matter how you term the structures, but you need to clearly define the structures to make sure that you correspond with other colleagues and can compare your results in an adequate manner. So definition, clear definition of the root structures is essential. Usually, or the right term for the aortic valve, cusp is cusp, not leaflet, although leaflet is generally adapted. Nature makes everything perfect. I think a perfect tricuspid aortic valve lasts a long lifetime, and if something is probably not perfect in nature, we are probably not able to understand it now, or we investigate structures on a way to getting perfect during evolution. Let's have a closer look at the structure of the aortic root, and an example here, aortic valve cusp. The attachment of the cusp, an endoscopic view on the 80 millimeters of mercury, and when we look closer to the attachment, we see this kind of arrangement of the different fibers. And as you know, these kind of structures are adopted not only here in bridges, resuspension bridges, but also you know that for airplane design or design of surfaces, nature has been translated into the daily business. And this is not only true for the aortic valve, also for the mitral valve. You can see here in this beautiful church in Barcelona the arrangement of the cordia of the mitral valve. Now, heart valve macro microstructure is a very complex network and structure. I would like to share you some of the findings I have made, and again, you see these different structures, and we analyze the sinotubular junction, the sinus tissue, annulus tissue, commissure tissue, and cusp tissue. And if you look closer here, Mason-Goldner staining of the sinus tissue, you can see the specific arrangement of collagenous fibers, muscular fibers of the endothelial layer in the sinus tissue. We find in the sinus tissue nerval structures with different densities of vesicles transmitting vasoactive agents. Here again, an axon with the dense core vesicles here. We also find neuronal or nerval structures in the annulus tissue, as you can see here. Again, a nerve seen here in an annulus section, electron microscopic. We also find nerval tissue in the commissure. And we find myofibroblasts or muscular tissue in the aortic valve cusps. And after we have stained this with antibodies against alpha-actin of smooth muscle cells, we could identify at the ventricle layer these kind of structures which can cause some active movements, active behavior of the structures of the root, indicating that it's not only, as initially thought, a passive movement and opening and closing of the aortic valve or the aortic root during the cardiac circle. It's an active mechanism. Again, other electromicroscopic investigations of the arrangement of collagenous fibers in aortic valve cusp. And we were also able to identify dose-dependent contraction of aortic valve cusps in organ bar studies, and we were able to identify receptors mediating these kind of contractions to a variety of vasoactive agents. And if you look at the aortic valve in a mock circulator during the cardiac cycle, we could see that the leaflet opening already starts to close, although the peak aortic flow is not reached. This has to do, obviously, with the so-called Venturi effect, but also there seems to be some active mechanism. And the theory is that the aortic root, aortic valve, needs to be trimmed like a sail of a sail ship during the different hemodynamic status in the aortic root, at rest and exercise. So it's the aortic root and outflow, it's a tale of dynamism and crosstalk, as Professor Jakub beautifully termed it. Therefore, it's necessary to preserve the aortic valve in any case if it's possible. But there are, of course, status, as you can see, a severely calcified aortic valve where you need to replace it. And there are numerous of mechanical and heart valve substitutes which have been developed over the years, which show very good long short-term results. They have their shortcomings with regard to anticoagulation, etc. And they have especially their shortcomings to complications like thrombus formation, endocarditis, degeneration, and other complications, as you can see here. So again, we need an optimal and an ideal valve substitute, which is a native aortic valve, and if it's not functional well, we need to preserve it, because the ideal valve substitute has optimal hemodynamics, so no gradient, no leakage volume, which is sometimes the case in prosthetic valves. It needs unlimited durability, anti-thrombogenesis, ease of implantation, of course, no damage to blood cells, it needs to be noiseless, and resistant to infection. I would like to point on the last issue a little bit closer at the end of the presentation. So Professor Al-Khoury has a large expertise in aortic valve repair, and he has shown the principles of aortic valve repair, because usually aortic valve, even if they're insufficient and have the potential to be repaired, it's a very complex structure, not fully understood by many surgeons. Therefore, they go the easy way and replace the valve. There are different principles with regard to reconstruction technique of isolated root structures addressing the cusp and the root itself. So it's a plication, resection, patch augmentation, and reinforcement of the cusp if a prolapse is present with PTFE. And then, of course, root reconstruction technique. The easiest one is the subcommissural annuloplasty, sinotubular junction plasty, and then the two reconstruction, implantation, remodeling techniques, so valve preserving procedures, I would like to focus a little bit closer on. If you look at the guidelines of the big communities in which patients the valve should be repaired, or which patient should undergo surgery in patients with severe aortic regurgitation. Basically, it's a class 1 level for patients who are symptomatic, have a poor ventricle, and needs to undergo other operations. In these patients, there's a clear indication to perform the surgery, and also if the LV function is preserved, but already the diameters of the heart are increased. And indications for aortic root surgery, which often causes aortic regurgitation, even in the presence, if there's no severe aortic regurgitation. These are the indications when to perform surgeries, but you can see here this is a 2A classification, and the diameter seems to be changed. Surgeons seems to be more aggressive to correct even these kind of dilated aortas at an earlier stage. So in current practice, again, valve replacement still remains the most widely used technique, but the proportion of valve repairs procedures is increasing in experienced centers. And I think this is important. It needs to be in experienced centers with an expertise in valve repairing techniques. And a lower threshold, as I said and pointed out, of the aortic diameters may also be considered in low-risk patients. So there's a trend towards a more aggressive treatment if the aorta is dilated, causing or causing not additional aortic regurgitation. Some surgical techniques, so cusp plication, as you can see here, prolapsing cusp is plicated in the way that whatever material you use, the free edge of the leaflet is brought to the same level of the cusp of the other cusps. Again, this is subcommissural annuloplasty, so the trigones underneath the commissures are corrected with regard to the angle. Here you can see additional plication sutures at the free edge of the cusp. This is an example of a hole in the cusp which can be patched, and then cusp extension, usually in more third world countries where you have shrinkage of the free edge of the cusp, and then the cusp is extended by autologous tissue, but usually these cusps here would be replaced. As I said, the aortic root and aortic pathology is often accompanied with aortic regurgitation, and both can be preserved. And especially in Marfan syndrome, you see often this kind of grotesque aortic root. It's a dilatation of the aortic root and usually a very small remaining aorta. And these valves can be repainted. And there are basically two principal techniques, which is the Yacoub or remodeling technique introduced by Professor Yacoub in 1983, and then the David operation or reimplantation technique, where the aortic valve is trimmed in the way I already presented you, and then reimplanted in a straight tube graft. This is how the aortic root is prepared for basically both techniques. You see the sinuses are cut away. These are the coronary ostia, and then it depends how you perform the Yacoub procedure. The graft is trimmed with 3 individual tongues. And this is an example of the reimplantation technique. So the aortic valve is reimplanted in a straight graft, which has the advantage of going down towards the annulus and also the base of the annulus, giving some stability in that area. There are modifications of both techniques because it has been shown that there are some shortcomings, and I will come to that later. So basically, what we call David 1 technique is the classical David, where the aortic valve is reimplanted in a straight graft. David 2 is like equal to the Jacob, the 3 tongue shape Dacron graft, and then we have the David 3, which is the Jacob, and stabilization of the annulus with an annuloplasty. David 4 is some sort of shrinkage at the sinotubular junction. David 5 is some shrinkage of an oversized graft at the annular level, just to recreate some sort of sinus or neosinus or pseudosinus for better valve performance. And then the David 4 Stanford modification is some oversized graft and tailoring at the base and some smaller graft at the sinotubular junction. There are also commercially available grafts like the Paulus prosthesis, which has 1 pseudosinus, and then the Trubita graft and the Unigraft bioprosthesis, which you will hear later on in another talk. So what we try to do is imitate the geometry of the aortic root by different types of prosthesis. And we have investigated this again in a mock circulator, so we use different types of prosthesis with different shapes, and had a look at the aortic valve performance. And with the remodeling technique, and this is the big advantage, that we could find that the hemodynamics are more closer compared to the physiological hemodynamics of the native aortic root compared to the David 1 procedure, where the aortic valve is reimplanted in straight graft. And these are the examples. This is a native aortic valve. You look with a high-speed camera, 500 frames per second on this aortic valve, and look at the free edge of the cusp. With the David procedure, you see this kind of, folding of the free edge, which is not the case in the Jacob procedure. So the aortic cusp open and close much more harmonic in the Jacob procedure. What about the clinical implications, so the results? And Professor Jacob had looked at it already in the late 90s, and here is a series of 158 patients, and if I recall it right, I think it was 42% dissections, and he looked at the elective and oral results. So this is the results of all patients' survival, and you can see here long-term survival at 10 years is quite favorable. The Hanover group had also looked at the long-term results, and they exclusively, and also I think still up to now, they exclusively used the David 1 procedures. And it had been the concern of the David 1 procedure that the cusp touched the graft, and this could interfere with long-term performance. They analyzed their data, and they could find that survival after discharge is 70% at 10 years, and patients' risk of freedom from reoperation at 10 years was 87% in this series. David has also looked at his long-term data, and aortic valve reoperation or freedom from was 98% in his series. And much more important than looking at the rate of reoperation is the rate of aortic regurgitation or insufficiency, and it was 93% in his series at 15 years. So excellent long-term data with the David 1 procedure. Initially, I think he used also the remodeling technique, but these are for the reimplantation in the straight graft. So the theoretical advantages of the cusp not touching the graft may not have an implication of long-term performance. Again, a quarter of a century experience with the David procedure here in this series. Predicted mortality after 20 years here, and then patient survival in comparison. And again, both techniques compared here, they have freedom from moderate to severe aortic regurgitation. Both techniques are similar in this series. we also looked at our data and looked at the factors, and we used a specific model where we started with some, it's a complicated model looking at different echo data, because echo is not always performed of 6 and 12 months, so we looked at the echo data. And what you find here is that you start with an intercept, what is called intercept, and then a slope. So it's the initial grade of regurgitation and the increase over time. And we can see here that all patients, reimplantation and remodeling, they increase with regard to aortic regurgitation over time, differentiating in David and Jakub, but the increase is very small. However, we could see that with the remodeling technique, patients with a small aortic root, small aortic annulus, put it this way, have a more stability of the results over time compared to patients with a large aortic annulus. And in contradiction of the David procedure, patients with a large aortic annulus have favorable long-term results compared with small aortic annuli. So it seems to be that in small roots perform a Jakub procedure, in large annuli a David procedure, or a Jakub procedure with some sort of annular reinforcement. And in our series, which is not the case in the series of Brother David, who had, I think, 62% of also cusp intervention, couldn't see any difference, but we could see that in our series of Jakub and David procedures, any additional intervention at the cusp was had a disadvantage with regards to the development of the regurgitation. This could be attributed to the surgical technique. Another important effect is quality of life in these usually quite young people. And this series from Bad Homburg showed that especially physical function and general health, when you compare group 1, these were the valve preserving technique, to group 2, mechanical valve was favorable. So the question is, for what valve, which surgical technique? And a tool which may help us predict before the operation how we should perform the reconstruction technique, and then try to imitate this kind of reconstruction technique in modeling, is this kind of 4D imaging, where we take patient-specific data, MRI data, CT data, echo data, merge them, and then mark specific points and try to vary in models how specific techniques would interfere with the outcoming results, or what technique we should use. Another interesting aspect are bicuspid valves. You can see an MRI of a bicuspid valve, the fusion of two cusps. And again, it's most important that these kind of bicuspid valves needs to be classified, and the most adopted classification is by Hans Sievers. It's very intuitive, it's from the surgical side, it's very reproducible, and I think it's the most adopted one. And it allows that also surgeons worldwide can compare results with regard to this classification. And it basically works that you look at the tricuspid valve, look at what kind of cusps are merged to each other, how many cusps are merged to each other, and then they're classified with regard to type 0, a true bicuspid valve, only 2 sinuses, type 1 where 2 cusps are fused, and type 2 where 3 cusps are fused, and you have like these kind of only 1 opening. And there's a correlation, and that's why bicuspid aortic valves are so interesting, in my view, that there's a correlation between bicuspid aortic valves and disease of the aorta. And it's not completely understood. It's the question is, and we have heard about it before, hemodynamics is a genetic thing. And the ascending aorta is not changed in a single way. We see different pathologies, different kinds of dilatation of the ascending aorta, and different types of bicuspid aortic valves. And the model we used in Leipzig is we use mini pigs and put them into the MRI and developed this kind of fancy flow visualization. And then we took them into the OR, and then we performed bicuspidization of a tricuspid valve with a Sievers type 1, so where we fuse the left and right coronary cusp, and then we put them into the MRI again, we could see these kind of vortices. So at least this gives you some idea that may also this kind of bicuspid valve flow dynamics play also a role in the development of aortic valve disease. By incident, we found one mini pig who had a true bicuspid valve, and we tried to breed and get more pigs out of this series to investigate it. Initially, I told you, and this is the last part, the innovation part, that the ideal valve is also resistant to infection. And it's the most catastrophic disease we see, and we see every second day a patient with native or valve endocarditis in Leipzig, sometimes with severe abscesses. It's a real disaster, and you can see here either native valve endocarditis or prosthetic valve endocarditis. And there are criteria which patient should be operated on, and the best way, again, and this is the link, is to preserve as much as possible of your native valve to make sure that you don't get this disastrous disease. And there are criteria like the Duke criteria, who are the reference criteria for deciding if it's an endocarditis, yes or no. You have one major and minor criteria, echocardiographic and blood culture criteria, and then minor criteria, for example, accept embolic events and fever. And you have some sort of criteria. And we don't see only these 5 bacterial groups we have numerous bacteria who are responsible. And if you look at the patients we have operated on infective endocarditis, only half of them had positive blood cultures. 1/3 have a positive blood culture of the tissue sample itself, and only a minority were positive on both. And the use of molecular approach is very, very favorable in this regard. And what we did is that we used this molecular diagnosis, and we were able to find 100% agents, the bacteria, in tissue samples. And we are in the process of getting a bedside test of a ship where we take blood samples from the patient. Within half an hour, we will find what kind of bacterium is in the tissue and what kind of resistance to antibiotic agents this bacterium has. Another, and this is the last point, is electron microscopy, focused ion beam scanning, and this is work of Dr. Andreas Oberbach together with Zeiss. And what you can find here are the valve surface with electron microscope. You can see here Streptococcus gondii, and this is a patient also, Streptococcus gordonii. This patient had 8 different bacteria. And the innovation now is that we use this FIB electron microscope and make thousands of slices and some sort of 3D reconstruction. And with complex measurements, we are able to find that the bacteria, which we don't find in our swabs on the surface, but when we cut into the tissue, they're actually lying in the tissue. And then these brown ones, these are all bacteria. And again, this is the aorta in its intramural, and this is the aorta mitral curtain, intramural in patients with endocarditis, but these are areas which are obviously on the surgical side not infected. But we see here in this intramural that there's a lymphocyte, and these are all bacteria. So these techniques allows us that we find an explanation why our antibiotics don't work. So you can see here, this green and yellow, these are bacteria, and then they are within cells, red and blue cells. So that's why probably our antibiotics don't work. And again, even if you have antibiotics which go intracellular where we find the bacteria, in this example, sometimes we even find bacteria which have small holes and they actually spit out the antibiotics. So I was hoping to demonstrate you, or give you an idea of the complexity of structure and function of the aortic root. And I strongly encourage you that with your basic research, communicate with us, and we need to communicate you. And I think these kind of symposiums are an excellent tool to translate what you found into the clinical setting and tell you what we find clinically. Thank you very much.
Thank you very much indeed, Martin. Excellent presentation as usual. We have a few minutes for discussion.
Two small.
Very short question and very short answer, Martin, please.
Two short comments. When you showed the valve open early in systole, the ventricle starts to relax about a third of the way through what we call systole, and you saw there was a reversal in the pressure gradient or pressure difference between the LV and AO, and that has to do with the inertial effects of blood flow. The second is that we did a study that was presented in the 2003 meeting, and there's another advantage to the graft that contains sinuses, and that is it improves coronary flow. We were able to show that you got a smoother, you did not get flow convergence within the first couple centimeters of the coronary arteries that occur when implanted into a linear graft than if you have grafts with sinuses.
Thank you very much. Excellent comment. So the aortic root is not an individual formation and interacts with the ventricle. Yeah, you're completely right. It just shows how complex it is. And with regard to the forces, exactly, that's very, very important. What I'm trying to emphasize is whatever you do, we're still putting rigid tooth, whatever shape, into your aortic root. I think we need to look for different materials which have elasticity and danceability to perform grafts. We still use the grafts we used, I don't know, 20, 30 years ago. So the way is...
The classical experiments of Bellhouse and Bellhouse published in Nature some time ago show the importance of the sinuses in directing systolic pulmonary coronary flow, and that the position of the coronaries is critical to this reversal of flow into the sinuses. Ismail, short.
Martin, I know you're a proponent of the Ross operation, but you're now in a center where the Ross operation is not very favorable. What I would like to hear your comments on is and what always bedazzles me when we look and we go to meetings is how well accepted valve sparing operations are within the surgical community, and yet the underlying principle is the same as the Ross operation. We try to preserve as much living structure within the aortic root as possible, although the only thing living in the valve sparing is really the valve and the subannular. And yet the results, up to 10 years or 15 years are still for rates of reoperation, which if we look at most centers are probably higher than what we observe with Ross operations, probably a bit more than 10% at 10 years or so, which is the biggest Achilles heel for the Ross operation as far as most people. So how would you comment on that, coming from
3 words.
Indication for Ross different, so indication for preserving. Aortic regurgitation is no indication for Ross, and in the majority of aortic regurgitation you either reconstruct the valve or perform preserving techniques.
Thank you, Martin. Excellent. We have to move on.